Welcome once again into the Radiopedia reading room for a podcast unconcerned with books or poetry, tea leaves or palmistry. This is a radiology podcast. My name is Andrew Dixon, and joining me, he's always a little bit twisted, but this week he has an excuse. It's my co-host, Frank Gaylard.
All things considered, Dixon, I think you're lucky that I've even bothered showing up.
You say that almost every week. Why is it this week?
Well, Singapore took a bit out of me, to be honest. So just a quick recap. This year, we decided to relocate to Singapore, of all places, during the conference. Why Singapore, considering it's an online virtual conference? Well, it was a way for the two of us, along with Vikas Shah and Andrew Murphy and the wife of the podcast, to sort of hang out together. It was a little bit closer to Vikas, who had to come all the way from the UK.
And to do a lot of work if you're the ATO listed.
We did a lot of work. We actually did until 5 p.m. Because at 5 p.m. There were free cocktails from 5 to 7. And 5, I mean, it's quite early to start with free cocktails.
Yeah.
And so I think over the course of the week, it would be fair to say that starting each evening with a 2-hour session of free cocktails often impaired judgment of future alcohol consumption. And so anyway, since having arrived back a week ago almost now, I've been almost dry. Last night was my first alcohol since Singapore.
Yeah, I haven't touched a drink since. For me, it was not so much the alcohol, but the buffet breakfast and the canapes and the and the airport lounge. Although we used to call them canapes. Remember, we called them canapes.
Canapes. And Vikas got very confused after a while.
He was like, "Is that what they're called in Australia?" But yeah, that was way too much food for me. But it's very good to be home now, with nothing but empty cupboards and stale bread in the house. But we did catch up with some podcast listeners and some Singaporean conference delegates, Gaylard.
Yeah, that was awesome. With cocktails. It was really nice, actually, to catch up. There was a whole bunch that met us at a bar. And thank you, Amanda one of our editors, who's a Singaporean radiographer, who really helped us organize this at the very last moment and was so much fun to hang out with. It was great. It was the first time we all met up in meat space, so to speak.
I didn't know, though, that there was a 10% tax added after the price of the bill, and then also a 10% service charge. so it did make the drinks and the food a little bit more expensive, but I think we'll cope.
We'll cope.
Anyway, I am glad you've made it along today, Gaylard. And the reason that I said a little bit twisted in the intro is that today's main segment is a readful episode focusing on ovarian torsion. So it features the one and only Vikas Shah and Emmeline Lee. And I don't actually need to give it any more introduction than that, because Vikas explains the whole concept and introduces M better than I could possibly do. Ovarian torsion is what we're going to listen to.
Good. But hey, before we do that, I want to read out an email from a longtime listener and dear friend, Thomas Rego.
Yeah, go for it.
Okay, so Tom writes, "Hi, Frank and Andrew, or rather Andrew and Frank. Love the podcast. Keep up the good work. I spotted this article today, and the article is titled, 'Man Wearing Large Metallic Chain Dies After Being Sucked into MRI Machine in the US.' And of course, the link to the article is in the show notes. And the article goes on to say, a 61-year-old man has died after being sucked into an MRI machine at a medical center in New York. Adrian Jones McAllister said she was having a scan on her knee when she asked the technician to get her husband in to help her get off the table, a task he normally did at her appointments. She said he was wearing a 9-kilogram chain with a lock that he used for weight training. So at this point, I have to stop, and I have to say that I went online to try and find what such a neck weight training chain looks like.
Yeah.
The only things I can find are these pretty funny head gear sort of helmet contraptions that you hang weights off that I've seen Formula One drivers use because, they all really have thick necks because they need to stop their head being snapped off as they go around a corner. But I can't imagine that it's this that he was wearing, because there's no way you can wander around with what looks like a soft helmet with sort of a chain dangling from your ears and no one noticed. So he must have had something else. Anyway, the man walks into the room and the article says, at that instance, this is the wife speaking, so it must have been horrific. And I'm not trying to make light of this. Okay. The wife says that at that instant, the machine switched him around, pulled him in, and he hit the MRI. Miss Jones McAllister said the technician helped to try and pull Keith off the machine, but it was impossible. She said, "Can you turn off the machine? Call 911, do something, turn this damn thing off." And he waved goodbye to me, and then his whole body went limp. The man was taken to the hospital in critical condition before he died on Thursday after suffering several heart attacks, and a police investigation is ongoing. And so Tom goes on to ask a question for you. How dangerous are MRI machines for bystanders? Are radiologists and radiographers some of the bravest clinicians in the hospital working with all this radiation and these dangerous magnets? So what do you think, Dixon?
Look, superhero is a word that is bandied around quite a bit. We don't all wear capes. No, actually, Tom's a psychiatrist, right? I think they've got to be up there for the bravest medical practitioners if they're dealing with thought disordered patients. If I think back to medical school when I was sitting in the room doing interviews with some, or do most psychiatrists these days just sit back and prescribe ADHD drugs during $1,000 consultations? Maybe.
I'm sure some do, but not Tom. He's in the trenches. Mostly old age psychiatry, actually.
Okay.
So he has to fend off aggressive psychotic octogenarians, I guess, that are trying to hit him with handbags. He's a real hero, not us.
He is. Perhaps I need to send my mum his way. Anyway, that 8 kilogram, 6 kilogram bling, that's
a lot of bling.
That's a lot of, that is massive. One thing from there, I noticed in that article they said technician. And I think the preferred term these days is technologist, isn't it? So MRI technologist rather than technician. So we need to contact the ABC and get them to update their terminology. What about those helicopter retrieval doctors? They're pretty brave.
Just going into a helicopter.
Actually, I saw footage the other day of one of those retrieval teams in remote Tasmania, and they were freeing this man who was trapped in rapids by his leg, and they actually had to cut it off.
What, in the water?
Yeah, in the water. Yeah, they had to reach down. Yeah, amazing. Anyway, getting back to that MRI, tragic death, obviously, but public service announcement, that MRI magnet is always on. And you can't just switch it off. So, never take being in its presence lightly.
Well, when you say you can't switch it off, years ago at my hospital, a cleaner went into the MRI machine and then closed the door on himself and couldn't open it from the inside and was looking around for some sort of button to call, and he accidentally hit the quench button. Well, not accidentally. He hit the quench button, which was apparently extremely impressive from the street, as a couple of $100,000 worth of liquid helium suddenly got vented.
Yeah.
That turned the machine off. So I guess they could have done that maybe. But yeah, it's easy to become complacent around MRs because the danger's invisible, and around radiation, I guess. It's no different though, I think, to being around big industrial machines. And you wouldn't just, casually walk around a sawmill or a steel foundry because you'd see the danger. But because our equipment is invisible, and it's also nice and white and clinical and friendly looking, it's easy to forget.
Yeah. And also you get fatigue from seeing all those kind of little notices that do alert you to radiation or strong magnet because you're there every day. So you've really got to pay attention. And all you can drink, 5 p.m. to 7 p.m. cocktails plus MRI scanners, that definitely doesn't mix.
No, kids, don't drink and scan. My wife actually got her stiletto heel stuck to the side of the MRI, not realizing that it had an iron pin in it. She eventually managed to yank it free. But actually, that reminds me, years ago when I was a trainee, I was hanging out at the scanner reviewing a patient on the table before they got off who was having a general anesthetic. And the anesthetic registrar, who was a young woman, asked if she could go into the room to fiddle with something. You know what anesthetists are like. They're always fiddling. They're injecting a bit of this, sometimes into the patient, sometimes not.
Doing a Sudoku, sometimes not.
That's right, checking their shares, whatever. Anyway, she had to go in. So she put her keys and her swipe card and her phone on the desk and then walked into the room after having patted herself down to making sure that she hadn't left anything in her pockets.
Mm-hmm.
She got about a meter into the room when she went incandescently red, blushing. Her face just went from normal color to just the biggest blush I have ever seen. And she turned around and came out immediately and said that she can't go in there. And it turned out that she had a piercing somewhere.
Yeah.
I don't know where. She didn't go into details, but that the magnetic field started presumably doing things to that piercing. So she had to send her boss in, who tried to keep a straight face, but was struggling. So there you go. That's another public service announcement.
That's about as good a segue into women's imaging as
Yes,
I could possibly expect from you, Gaylard. So it is time once again to give the listeners what they're here for. It's time for the smoothest voice in radiology, Dr. Vikas Shah. He's chatting with Emmeline Lee about ovarian torsion. We'll listen in, and then Frank and I will be back for another chat in the outro.
Hi everyone, welcome to this discussion all about the imaging features of ovarian torsion. My name is Vikas Shah. I'm one of the managing editors of Radiopedia, and I'm an abdominal and emergency radiologist. I'm delighted to be joined by Dr. Emmeline Lee, who is a women's imaging specialist radiologist from Perth in Western Australia. Hi, Emmeline.
Hello, Vikas, and hi, everybody from Down Under.
It's always a pleasure to chat with you. And whenever we get a chance to meet up and have a discussion, I'm really glad you said yes when I reached out to you. So let me just explain for our audience what it is that we are intending to do here. So this is what we call a readful. So I will read out our Radiopedia article about ovarian torsion. Along the way, we'll show some images that explain the concepts and the key signs. You may be watching this in video format, or you may well be listening to this as a podcast episode. So we will do our very best to make sure that we make things clear whichever way you are joining us. Okay. So does that sound good, Em? Shall we get started?
Absolutely. Let's rock and roll. Like torsion. Gosh, sorry about that bad joke. Think I'm going to stick to radiology as a career rather than stand-up comedy. Sorry, because
So I'm actually not sure what would be better, Em, you doing one of your comedy sets or perhaps singing Twist and Shout?
oh, groan. That's pretty bad, Vickers. I can hear everyone groaning from there, but never mind. You'll be relieved to hear that we will be sticking to radiology rather than karaoke or stand-up comedy during this piece. And we'll have fun doing it.
Yeah, we definitely will have fun doing it. Okay, so let's get going. So the article that we're going to discuss is how it stood as of June 2025. So it may well have changed by the time you watch this or listen to an audio version. The article title is Ovarian Torsion, and the opening paragraph is: ovarian torsion occurs when the ovary rotates around its supporting ligaments, twisting and compressing the accompanying blood vessels and lymphatics. The term adnexal torsion is preferred because a portion of the fallopian tube is commonly torted along with the ovary. The term adnexal torsion also encompasses rarer entities that do not affect the ovaries, such as isolated torsion of the fallopian tube and torsion of paratubal, broad ligament, and paraovarian cysts. The diagnosis is commonly missed, which leads to delayed surgery and complications. There's a subsection called epidemiology. The true incidence of adnexal torsion is unknown. One estimate suggests that up to 3% of women presenting to an emergency department with acute abdominal pain have ovarian torsion. Although most cases occur during reproductive years, the age range extends from prenatal to postmenopausal.
So radiologists may actually be the first people to make the diagnosis because of the really variable and vague presentations of ovarian torsion. And the fact that symptoms may sometimes be intermittent and may be coming and going for several weeks or even months before presentation. This is because actually the lesion may resolve on its own and then recur. And interestingly, a patient with early ovarian torsion may have different symptoms according to their position. So interestingly, a gynecological colleague of mine once told me that he used to actually lay patients on their sides and see if patients resolved. And if that happened, he would make a clinical diagnosis of ovarian torsion. And of course, that doesn't happen so much anymore these days because radiology is just so readily available that we may be the ones making that diagnosis rather than it being a clinical one.
Yeah, just like in a lot of other areas of imaging, what was the old teaching of something being a clinical diagnosis, the paradigm is shifting, isn't it? That radiology does become the primary kind of tool for making the diagnosis. Now, in that opening paragraph, I mentioned fallopian tube. This is also known as the uterine tube or the oviduct, but it's known as fallopian because it was first described by Gabriele Fallopio, an Italian anatomist from the 16th century. One thing to note is that despite the eponym, so despite being named after Gabriele Fallopio, the word fallopian is usually rendered in lowercase because it's an adjectival form derived from a name, not the name itself. So for all the pedants out there, and I know there are plenty, you can happily correct any uppercase Fs to the lowercase when you see them in reports.
That's really interesting. And because did you know that the same actually applies to Nabothian cysts? They're actually named after a German physician called Martin Naboth. And similarly, it's also an adjectival form. So therefore, we can use the lowercase when we're talking about Nabothian cysts.
Perfect. Grammatical education as well as radiology. What more can you ask for? Okay, let's carry on with the article. So the next section is called clinical presentation. Patients typically present with sudden, very severe pelvic pain, either intermittent or sustained. Often, patients report similar episodes during the previous month. Sometimes there is a history of vigorous activity, and confusingly, the pain can radiate to the flank, groin, and back. Nausea typically coincides with the onset of pain, and vomiting may follow. Nausea and or vomiting accompanying pain are helpful clues to the diagnosis in 85% of cases. Leukocytosis and fever are common and may indicate necrosis. Tenderness may be focal, diffuse, or not apparent. Ovarian torsion has an increased incidence throughout pregnancy and the postpartum period, but especially between 10 and 17 weeks gestation, related to persistent corpus luteum cysts. Ovarian torsion has been observed in the fetus. Clinical features in small children are typically non-specific, such as vomiting and restlessness. Pain may be diffuse.
So, one of my favorite bits of this article is that ovarian torsion can actually occur in the fetus. Most commonly, it is discovered during routine third trimester scanning, where a female fetus has an abdominal or pelvic mass. It can look like anything depending on what the underlying cause is. Say, if it's a hemorrhagic cyst, that's going to look different from, say, a dermoid cyst. But of course, the main thing is that you see a mass which is avascular in a female fetus. This is a really tough diagnosis to make in utero. So we as radiologists don't often make that specific a diagnosis, but we identify it and then we ask for postpartum imaging. And interestingly, if the mass is persistent postpartum, in an Italian study from 2022 by Romiti, 92% of those fetuses actually had tortured ovarian cysts. So, this is super important, but though not very common, it is something that you will come across in your daily practice.
Thank you. Yeah, and I think my general takeaway from that section was that the presentation can be quite non-specific. And we use that term non-specific a lot, don't we? But what I mean is that there is nothing uniquely characteristic about the presentation, and that in order to make it, you must at the very least keep it in your mind as something to think about. And that's very important, and we'll describe all the different signs that you should be looking for further down the article. Okay, so let's move on to the next section, which is all about pathology. The ovary is mobile, suspended by the infundibulopelvic. I've got to take my time when I say that. Infundibulopelvic or suspensory and utero-ovarian ligaments. The ovary has dual blood supply, primarily from the ovarian vessels in the infundibulopelvic ligament, and these anastomose with uterine artery branches in the utero-ovarian ligament. Torsion occurs when the ovary twists around these ligaments. Lymphatic, venous, and arterial obstruction varies according to the number and tightness of the twists. Lymphatic and venous occlusion causes central ovarian edema, which further compromises arterial inflow. Hemorrhagic infarction can then follow within hours. Over 85% of cases are associated with ovarian enlargement, so 5 up to 30 centimeters, due to a mass or cysts caused by, and then there are 4 items listed: corpus luteum, ovulation induction, so multicystic ovaries or ovarian hyperstimulation syndrome, polycystic ovarian morphology, or benign mass, commonly a mature cystic teratoma or adnexal cysts. Endometrioma, tuber ovarian abscess, and malignancy are more likely to have pelvic adhesions and are less likely to tort. However, malignant tumors may account for 3 to 20% of cases of torsion in postmenopausal women. Hypermobility of the ovary due to relatively lax ligaments may be a factor in children and teens. Isolated tubal torsion is predisposed by hydrosalpinx, hematosalpinx, paratubal cyst, ectopic pregnancy, or elongated mesosalpinx with a tortuous tube.
Yeah, so knowledge about radiological anatomy is super important here because understanding the dual blood supply of the ovary and the ligaments these blood vessels traverse through is very important. Because of this, if we image ovarian torsion early, there may be preserved vascularity. So, this is a really important practice point that even if you see persistent color flow on Doppler imaging in the ovary, you still need to consider ovarian torsion in the differential diagnosis in any female with pelvic pain. Another point to note in this section is that most of the time in adults, ovarian torsion occurs when the ovaries are enlarged for whatever reason, either a physiological cyst like a corpus luteum or something pathological such as a dermoid cyst or hemorrhagic cyst.
That takes us very nicely into the next section, which is all about the radiographic features. And one of the important points we'll discuss is the vascularity and enhancement. Okay, so the section is called radiographic features. The key features of torsion are ovarian edema and swelling due to venous and lymphatic engorgement. This exacerbates arterial compromise and can cause hemorrhage and infarction. A normal ovary measures approximately 4 by 2 by 3 centimeters with a volume of 9.8 cubic centimeters. Following ovarian torsion, a maximum diameter of more than 5 centimeters is 89% sensitive. Additional concurrent imaging characteristics which indicate adnexal torsion include, and then there are a few bullet points listed: rounded or spherical ovarian shape. A torted ovary shifts towards the midline to lie anterior or posterior to the uterus. The uterus is deviated towards the torted ovary. A twisted vascular pedicle, which may be apparent as a layered whirlpool structure between the uterus and ovary, and that comprises the fallopian tube, mesosalpinx, and the vessels. Edema and fluid expands the central stroma, displacing the follicles peripherally. A distended fallopian tube and peritoneal free fluid.
So many gems in this section because every candidate leading up to their final radiology exams know these signs, and it's really important that you do know these signs inside out. And of course, the ones with the most yield are an enlarged midline ovary with whirlpool sign. I think the whirlpool sign is really important if you see it, and peripheral follicles.
Yeah, let's look at some images now to show some of these signs. So for everyone listening to an audio-only version of this, I will try my best to describe what I'm seeing. So this is an ultrasound case which was contributed to Radiopedia by Dr. Maulik Patel. It's of a 35-year-old woman, and the images show an abnormally enlarged right ovary with edematous stroma and an echogenic rim with multiple small follicles. The fallopian tube is thickened and there is no Doppler signal in the right ovary. So this patient went on to have a laparoscopy and the right ovary was non-viable. And there's a video from the surgery showing an edematous and purple fallopian tube, which looks twisted, and the ovary has a similar color, and this was subsequently resected. Now, many of the features that I've shown you and are seen on this case are described in more detail in the first subsection of the radiographic features section, and that's titled ultrasound. So let's dig into that now. So ultrasound is the initial imaging modality of choice, and the sonographic features include, and there's a list of bullet points, and it goes over some of those key findings. So enlarged edematous globular ovary is the key finding. Ovary more than 5 centimeters in maximal diameter or more than 20 cubic centimeters in volume. Rarely normal size ovaries if there's isolated fallopian tube or para-ovarian cyst torsion. Stromal hypoechogenicity, so low echo because of edema, or patchy hyperechogenicity because of hemorrhage. Cystic or hemorrhagic degeneration, which indicates established infarction. Peripheral follicle surrounded by a hyperechoic ring. This is known as the follicular ring sign, most likely due to hemorrhage in the thecal layer. An unusual location of the ovary, anterior or posterior to the uterus, or a change in its position. Tilted uterus because it's pulled by the twisted ligaments. And then Doppler findings, which are variable. So little or no ovarian venous flow has a sensitivity of 100%, specificity of 97%. Absent arterial flow, which is less common but confers a poor prognosis. Absent or reversed diastolic flow. Asymmetric flow compared to the contralateral normal ovary. Normal vascularity due to intermittent torsion or good collateral flow. So there's a range of appearances. Whirlpool sign, this is the one we've been waiting for. Whirlpool sign of twisted vascular pedicle is pathognomonic and is helpful in cases with normal Doppler flow with sensitivity of about 90%. You might see an underlying ovarian lesion, which is the lead point for torsion. Ovary tenderness to transducer pressure, and pelvic free fluid may be seen in more than 80% of cases. Isolated fallopian tube torsion is rare, and the findings may include tubal dilatation with tapering at each end, so that's the beak sign, with thick echogenic walls.
Once again, lots of important signs to look for if you're the person on call and having to decide whether there's torsion or not. So, a great reminder of what we chatted about before, which is that Doppler changes may be variable and not that reliable. So, of course, if you see absolutely no color flow in an enlarged ovary, which has a midline placement with peripheral follicles and a whirlpool sign, that's just super easy and it's a slam dunk for everything, and that's ovarian torsion. Just be careful of dismissing ovarian torsion if you don't see any, if you do see color flow. Another important point to note is that diagnosis is much easier if you have access to transvaginal scanning. Of course, if you only have access to transabdominal scanning, it becomes a much tougher diagnosis. So I would like to make a big shout out to the people who do have to make this diagnosis with transabdominal imaging, particularly our pediatric radiology colleagues.
Yeah, big shout out to them. So that last case that we looked at had many of those features that we've just read. And because ultrasound is so important, let's look at one more case to review these signs. So this is a case uploaded to Radiopedia by Dr. Magdi Masoub. There are ultrasound images of a 4-year-old girl, and they show that the right ovary is enlarged and displaced to the midline, lying posterior to the bladder. The ovarian stroma is thickened and looks quite echogenic, and there are multiple small peripheral follicles and no signal in the ovary on the color Doppler imaging. There's also swirling of the vessels adjacent to the ovary, and that's the whirlpool sign. So I think pretty much a full house of the imaging signs that you'd be looking for in ultrasound. She went on to have surgery, and they did confirm a torted ovary. So we'll move on to CT and MRI to describe a few more imaging signs. So the next subsection is CT. If the clinical features are non-specific, CT may be the first investigation. And although not ideal, there are features that favor ovarian torsion. So there are 5 points listed. Edematous or hemorrhagic mass, anterior or posterior to the uterus, which then the uterus may be tilted, with patchy enhancement and adjacent free fluid. Peripheral follicles, known as string of pearls, if present, that can indicate that the mass is of an ovarian origin. There might be a mass such as a cyst or a mature teratoma. Soft tissue, vessels with or without fat at the anterolateral margin of the uterus can suggest there's a twisted pedicle, and then fat stranding in the adnexa is non-specific. Hemorrhage is a sign of potential necrosis. Heterogeneous increased attenuation on non-enhanced CT may indicate hemorrhage, whereas heterogeneous attenuation on enhanced CT may indicate either patchy hemorrhage or diminished vascularity. So you've got to make sure you know which one it is, non-enhanced or enhanced. Whatever the underlying cause, these appearances are a relatively poor prognostic sign. And then there's a short subsection on MRI. Sometimes the diagnosis of ovarian torsion is missed and the patient may be referred for MRI to evaluate a mass. And this delay makes infarction more likely. So T1 shows a thin rim of high signal intensity, that's due to met hemoglobin. T2 may have low signal due to interstitial hemorrhage. And post-contrast, T1 shows reduced or no contrast enhancement.
So I think radiologists are increasingly having to make accurate diagnoses on CT just because it's become so much more readily available in emergency departments around the world. So it is really important to be able to make the diagnosis of ovarian torsion on CT. And because most radiologists are presented with axial, sagittal, and coronal reconstructions, it is such an awesome way of making this diagnosis because you can actually see the tortured ovary not in its usual location laterally. You can see it medialized, and sometimes you can actually see that the mass is either very anterior or very posterior. So definitely use all the different ways that the CT is being presented to you. It's also really important to make this diagnosis on MR, particularly in pregnant women, because pregnant women have a 5 times increased risk of ovarian torsion because of the laxity of the ligaments, and also they can't have CT. So, and ultrasound is sometimes a little bit difficult as well. So, very important to recognize ovarian torsion on MRI as well.
Okay, yeah, let's look at a couple more case examples now, this time focusing on CT and MRI. So the first one is a CT contributed by Dr. Mohammed Amar. It's of a 35-year-old woman. There's a sizable mixed fat and soft tissue mass lying posteriorly, but connected with the ovarian tissue, which heads towards the right side. So it's the right ovary. And that ovarian tissue looks hypodense and edematous, with a trace of free fluid and some blurring of the fat planes. There's also a twist of the vascular pedicle of the right ovary. So that's the whirlpool sign that we saw a little while ago on ultrasound, and here it is on CT. So this is an example of an ovarian lesion, which in this case is a mature cystic teratoma, or some people call this a dermoid, causing torsion. She went on to have surgery and they detorted the tube and ovary and removed the teratoma, but because perfusion was restored, the ovary was saved. And we'll also look at a case on MRI as well. So as we said, ideally you don't want to be using MRI because the diagnosis should really have been made on ultrasound or perhaps on CT, but sometimes there's diagnostic doubt and MRI may be used to evaluate an otherwise indeterminate pelvic mass. This case illustrates some signs that you might see. So it was contributed by Dr. Amar Haoumi, and it is of a 35-year-old woman. The left ovary is enlarged and lies somewhat more medial than usual. There are some peripherally displaced follicles. And then if we look at the signal of the ovary, it's got an intermediate signal on T1, low signal on T2, and on post-contrast imaging. And there's just a little bit of rim enhancement to the periphery, but otherwise no enhancement of the bulk of the ovarian tissue. We can also see a twisted pedicle, including the fallopian tube. So that's the MRI appearance of the whirlpool sign. There's also edema of the pelvic fat. So this patient did go on to have surgery and they did confirm ovarian torsion. So moving on from the imaging findings, the next section of the article is called Treatment and Prognosis. Urgent surgery is indicated to prevent ovarian necrosis. The appearances at surgery can be misleading. A non-friable blue or black ovary may regain function over time. Oophoropexy will prevent recurrence. A salpingo oophorectomy is appropriate for postmenopausal women or suspected malignancy. A necrotic ovary may involute, bleed, or become infected, leading to abscess formation or peritonitis. And long-term complications include pelvic pain, adhesions, and tubal infertility.
When I was doing clinical ONG a million years ago, in tortured ovaries that looked blue or black at surgery, oophorectomies were usually performed. But nowadays, there's increasing interest in preserving the ovaries if possible, especially if someone is quite young. So even if it looks really dire at time of surgery and it looks pretty terrible, people will still try and preserve the ovary, and gynecologists, they just untwist the pedicle and then pin it down to reduce the chances of this happening again.
Okay, so the next section is called differential diagnosis. Now, clearly, there is a really broad differential here, and this explains why in so many cases imaging may be delayed, but also why such a strong dialogue between the sonographer or the radiologist and the clinician is so important. So in this section, the differentials are listed as bullet points. So I'll just read through those. Ectopic pregnancy, positive beta HCG, so saying that's the helpful marker to be able to differentiate between the two. Ruptured ovarian cyst, you might find abrupt mid-cycle pain and free fluid or hemoperitoneum. Pelvic inflammatory disease has a more indolent disease course with signs of inflammation throughout the pelvis. Massive ovarian edema due to malignant lymphatic obstruction. An ovarian mass, we've described a few already. Degenerating pedunculated leiomyoma. Ureteric colic or urinary tract infection. Appendicitis, so an inflamed pelvic appendix might be seen on ultrasound. And inflammatory bowel disease.
Great list here, Vikas, and totally valid, because everything that was listed may cause pain clinically, and clinicians may find it really hard to differentiate one from another. And all of them would have positive findings in the pelvis. So it's a really good reminder here of the value of the pregnancy test in any woman in the childbearing age presenting with pelvic pain. Not that I'm obsessed with ectopic pregnancies, but I think this is a really important one to exclude because it's life-threatening if ruptured and if we miss it. Just a little practice point is that ovarian cysts can rupture at any time, but are more common in the post-ovulation stage, that is in the second half of the cycle.
Great, thank you for that tip. So we've now reached the final section of the article, and this is called Practical Points. And it's a bit like a TLDR summary of the whole article. So quite a useful way to end. And there are 9 bullet points listed in this section. So practical points. Almost feel like we should have one of those countdown, like those radio music countdown shows, the top 10.
Absolutely, we're morphing into music. I'm going to try and refrain from breaking into karaoke here, but absolutely, okay. This is great. Thank you.
All right, so practical points. The imaging diagnosis is often missed. Edematous swelling of the ovary is the hallmark of torsion. The affected ovary may be too high or too low, or maybe anterior or posterior to the uterus, and the uterus may be tilted. Whirlpool sign is specific but difficult to identify on CT. The absence of ovarian Doppler flow is highly specific for torsion, but normal Doppler flow does not exclude torsion. The presence of blood flow is a marker of viability. An ovarian mass presenting with severe pain is suspicious for torsion. Masses are rarely painful otherwise. And ovarian masses causes thinning of the ovarian tissue. Smooth or eccentric thickening of ovarian tissue around a mass is suspicious for torsion.
So I think this is a really good summary of the stuff that we've been chatting about over the last half an hour or so. And I do hope that after listening to this, that you will think about the signs of ovarian torsion on imaging, whether it's on ultrasound, CT, or MRI.
Yeah, I don't think we can emphasize this strongly enough. Delays in making this diagnosis accurately do have real negative consequences for women. So a robust clinical assessment paired with high quality ultrasound imaging or CT where required are key elements. And hopefully after watching or listening to this, you out there, our Radiopedia community, can keep spreading the word. So go and take a look at the article anytime you want on the website. Just search ovarian torsion and it's the first result. There are lots and lots of cases to illustrate all of these imaging signs, and the main article will be updated with any new knowledge that emerges. But that's it for this discussion. Emmeline, this has been fun, and I hope we can do it again sometime soon.
Absolutely. It's always fantastic to catch up with you, Vikas, and with you, the Radiopedia community as well. And I hope to see you guys either in person or online very, very soon. Thank you all.
Thank you, Emmeline. And for everyone watching or listening, I hope you found this useful. Bye-bye.
Now, normally I'd say so smooth right now, Gaylard, but Vic has actually told me when we're in Singapore that he officially doesn't think he has the smoothest voice anymore. He was very impressed by the smooth tones of Michael Nell's anatomy lectures during the conference.
Yeah, I mean, Michael is very smooth. But I think it all comes down to how you define smooth and your personal preference of vocal timbre, is it? Timbre.
I should say that the reason we say smooth actually relates to how well the automated subtitles pick up Vickas's voice. So Murph was the one who dubbed him the smoothest voice in radiology actually for this reason, because, he's just the easiest person to subtitle. Anyway, Gaylard, do you have anything insightful to say about ovaries for this episode?
Nope. Not about ovaries. The whole idea of all these squishy bits in the abdomen just gurgling and peristalsing and moving around is weird. When you think about it, it's the only place in the body where things are just sort of shoved in willy-nilly. And we spoke at length, probably after a number of cocktails, about how I pack my suitcase to keep everything nice and tidy and sorted during a trip. So the abdomen just freaks me out a bit.
Yes, getting sidetracked, but the women's reproductive stuff is always amazing to me because it really blurs the lines between what is inside the body and what is outside the body. Like, stuff isn't completely sealed. Just like your Ziploc bags hack, though, Gaylard. But that is perfectly sealed, isn't it?
Sealed to perfection.
Ziplocs. Do you want to tell people about it?
The best. I mean, I would for hours on end, but just get big Ziploc bags and your dirty clothes go in one. You can vacuum. Anyway, I'll leave that alone. But yes, the fact that the fallopian tubes sort of communicate with the peritoneal cavity and the outside world is kind of bonkers. And I've never quite understood the topology of that. In fact, as I was listening, I got stuck on the fallopian tube eponymous name bit.
Yes. I knew you would. As soon as I heard that bit, I was like, oh, here we go.
The problem was it was also at the start of the whole session. So that went on, and then I zoned out and went off on a little personal tangent because personally, I like eponyms. And I know they're often wrongly attributed and they're, vastly dominated by old white dudes. But there is something about the triviality of them that I find sort of charming. And not just in medicine. Did you know, for example, that the word shrapnel, from bombs, actually comes from a guy, Henry Shrapnel, who was a military officer who first invented the exploding anti-personnel shell.
Yeah, I think you might have mentioned that to me before off the podcast. But yeah, it's cool, isn't it? It's like Dr. Stent for stents, Dr. Worm for wormy and bones. I learnt that one during the conference. Yeah. And the song. Do you know the song, Dr. Worm?
I do not know
call
about
me
Dr. Worm.
Good morning, how are you? I'm interested. You don't know that one?
I don't.
I'm not a real doctor, but I am a real worm. I am an actual worm. You don't know this?
I don't know. That sounds like
just
they might be
entertaining
giants.
myself right now.
No, I don't know about Dr. Worm.
Hang on. I never get to say this. Link in the show notes to the Dr. Worm song.
Oh, yes, please. But I do know about stents. And I think actually he was a dentist and he didn't invent stents. He invented some sort of paste that held things open. And then the stent thing kind of grew out from that. So anyway, I find these little facts interesting, I guess, because it sort of reminds me that the world we live in is the way it is because of individuals that have created and invented things, and it's all sort of tied together. And a lot of it is really recent, like much more than before. It would never have occurred to me that the word shrapnel, for example,
No.
is only like it would be like finding out that splinters were named after a guy called Mr. Splinter who used to sell little bits of wood or something.
Yeah, who used to teach Ninja Turtles.
But yes, so I do like them.
Yeah.
That's what I thought about the whole episode, really.
Very good. Good work. Should we wrap this episode up then, Gaylard? Short and sweet. How can people get in contact with us?
Well, they can email us at podcast@radiopedia.org with any ideas and or feedback. And you can also join us on the Radiopedia community chat by visiting radiopedia.org/community.
Actually, speaking of emails and speaking of eponyms, Gaylard, we had a recent email. Jeppe from Denmark writes, in fact, it was quite prophetic that Vikas mentioned TLDR in that main segment because Jeppe has written a lot and included TLDR at the end, which is nice. So they write, "Hi guys, so I just finished your episode on Baum's loop, which was fun and a great example of something I think happens quite a lot in medicine, not necessarily with malicious intent and not per se direct misinformation, but this feedback loop of vague or less strong evidence that after some time circulating and being re-referenced in the academic literature becomes more solid and appears as almost literal truths, or at least stands unquestioned. I think often because authors don't take a deep dive into their references and maybe just go one level below their own." Before I continue with the email, Gaylord, actually, do you want to give a quick recap on the Baum's loop episode, fiasco, whatever you want to call it?
Sure, I think it was episode 18, which is a long time ago now.
Wow, off the top of your head, 18,
Off
he
the
knows
top.
them all.
No, I looked this up recently. You know why I know that it's episode 18? Because when I was about to talk about shrapnel, I thought, oh, this is the kind of thing that I probably have mentioned before. So I went to our transcripts and looked for the word eponym and did not find it anywhere. But I found it's used many, many times in episode 18. So
very good.
That's why. Anyway, Baum's loop is the eponymous name you will sometimes find in anatomy textbooks to describe the superior optic radiation, whereas Meyer's loop is the inferior optic radiation, or at least its anterior part. Sometimes Baum's loop refers to the superior. Anyway, it turns out that Baum's loop was introduced under, how can I put it, questionable circumstances. And Henry and I and a couple of the other radiopedians, we actually uncovered the truth through a bit of cunning detective work. And I won't spoil it because it's actually a really fun story of how it all got put together. So if you haven't listened to that episode, go back. It's a good one.
Yes, nice one. So I'll continue with Jeppe's email. I'm a radiology resident, but have a background in anesthesia, which here in Denmark, among other things, also work in the pre-hospital setting. When I did my neuroradiology rotation, I was doing some very light research on fractures of thyroid cartilage and hyoid bone, and I came across some articles that listed blunt trauma to the anterior neck as very common in motor vehicle accidents, and that the pre-hospital mortality was extremely high compared to what I imagined. Now, I knew something about airways from my background, so I crawled down the ladder of references to find where those numbers came from. Long story a little shorter, it was from some article from the 1960s before seatbelts and when car safety was very different. I know you guys are based down under where everything is trying to kill you, and maybe it is a bad example because of demographics. Maybe Australians hate seatbelts and daily get their throat crushed in via kangaroo-related collisions. What do I know? It's been 18 years since I was in Australia. Here we go. TLDR, an idea for the podcast. Deep dives into some radiology myth or some re-referenced statement in the literature that might be very old and not standing today's standards for evidence-based medicine. Stay rad, guys. Yeppe. What do you think of that episode idea, Gaylard?
I think actually two things. I think one, that would be awesome. But two, it sounds like it would actually require some work.
Yes. So maybe it could be your task to come up with this. This is a Gaylard episode, a future Gaylard
episode, a deep dive into some misrepresented radiology fact.
Yeah. I think it would be great clickbait kind of title as well. Radiology myths exposed or something.
Top 10 things you won't believe about radiology.
This is good. This is writing itself. It's probably gonna be our best episode ever.
Ever.
All right, let me read this bit here. And if you want to help support Radiopedia, then you can become a paid supporter via the website or purchase an all-access pass to our online courses and conference. Radiopedia 2026 is coming up in just over 360 days. In doing so, you'll be helping us to give free course and conference access to people in 125 low and middle income countries. And what else can people do to help us out, Frank?
By leaving a 5-star review in the podcast app of your choosing. And, leave an actual review if you have the time. Something funny, something we can read out.
I think you said this exactly the same way last episode. It's like,
did I?
Send us something funny. I want something
I'm
funny.
like
that kangaroo bit was pretty funny. That's good.
That was
so we need
good.
more of
that.
that.
Was great.
Yeah.
I mean, it would be funnier if it wasn't so true. 3 of my family members died this week alone from kangaroo-related accidents.
That's right. Yeah. And the kangaroos have started wearing these really heavy chains as well around then. All right, and we'll catch you again sometime soon in the reading room.
Stay rad, everyone. Stay rad.
Stay rad. Don't wear bling around the scanner.
Yeah.
Bye.